Jeff touched on the complexities of guiding consumers to choose high-value care, and our next few speakers will be sharing their research that can help inform efforts to engage patients in shopping for value. I'd next like to introduce David Auerbach. He's a health economist and Director for Research and Cost Trends at the Massachusetts Health Policy Commission. I first want to thank him for his help in pulling this webinar together. And mention that he joins us today to share their research on consumer preferences and which incentives lead consumers to seek care in lower cost settings. David?
Perfect. Thank you very much, Catherine. Yes, this is research that we've undertaken here at the Health Policy Commission in Massachusetts, along with, as you see in the front slide, some researchers at Tufts University. And this is based on a grant from the Robert Wood Johnson Foundation. And I'll just say the Health Policy Commission, as I refer to the HPC in the slides, we're a state government agency. We were created in 2012 with the mission of lowering the rate of healthcare cost growth in the state. We have a target benchmark, and also improving the quality to the extent that we can. So here I'll be talking about one of our strategies of attempting to do that. Okay. So here, by way of background, the HPC has consistently found that community hospitals, and by that I mean non-teaching hospitals in the state, provide care of similar quality and lower cost than the teaching hospitals we have in the state. And I'll just note that I talk in this study a lot about AMCs. These are teaching hospitals that are connected to, that are academically affiliated, and we have a lot of them in the state. There are 6, and they account for about a third of all inpatient discharges. So this is probably a bigger deal in Massachusetts and other states, but in general, a lot of what I'll be saying, we've talked to folks around the country, and a lot of the same issues apply in other metro areas. We just tend to have some supercharged teaching hospitals in Massachusetts. So the problem, or something that we're trying to address, is that Massachusetts residents do use these AMCs and teaching hospitals for a high proportion of their routine care that could be easily handled at high quality in the non-teaching hospitals in the state. And you can see that 42% of our Medicare inpatient discharges took place at teaching hospitals, much higher than the national rate. And we've tried to do a number of things about this in recent years. We'd like that percentage to be lower, and we've fostered the growth of tiered and limited network products, which might charge higher copays or out-of-pockets when patients do use those hospitals, the teaching hospitals. We've tried supply-side methods, which are growing in the state, like alternative payment models that would place the provider groups at risk for these higher costs. And those strategies have been working, but they haven't changed the needle on the proportion of routine care taking place at these teaching hospitals. So we sought to try to understand what's going on and what would it actually take. Is this an impossible mission? What would it take to get some of that care back to the community hospitals? So I'm going to go through a little bit of background, and then I'll get to the study. So I'll go try to quickly through some of the background. And much of this is probably not going to be surprising, but here we've lined up, for example, just the cost per case mix adjusted discharge by group of hospitals. The AMCs are on the left. The costs are higher at just about all of them than they are at the community hospitals that are shown on the right. We don't see any relationship between these costs and quality if you look at readmissions rates or other indicators. So you have about $1,500 more on average for a discharge at an AMC. And those were overall for all discharges, but if you narrow down to specific things or some of the shoppable care, such as hip and knee replacements or low-risk births, you see the same patterns. You can look at procedures that could be performed in hospital outpatient departments versus in the community. This is another example of something that we looked at in the study that I'll get to, for example, MRIs, higher cost in the hospital outpatient departments. This is showing by each of those. Here are 5 of the 6 AMCs. The green portion is showing the percent of their discharges that are for routine low acuity conditions and that are for patients that are coming in from the suburbs into Boston. It's about a quarter to a third of the discharges that they have. And so that green portion is the portion of care that we're trying to shrink. And this slide just shows that it's been a growing problem. If you look, for example, at the proportion of births that happen at the community hospitals versus the teaching hospitals, it used to be about 3/4, and now it's about a half. And these are low-risk births. Another time trend showing that on the bottom, the proportion of low acuity discharges that takes place at the community hospitals used to be about 55% in 2011, and it's slowly dropping. So this routine care is increasingly going to the teaching hospitals. And there's a large amount of money that would be saved if you could shift some of those discharges. Okay, so there's the motivation. This study had 3 parts to it. The main part that I'll spend most of the time talking about was a discrete choice experiment, a survey to about 1,000 Mass residents where we asked them about their preferences and changed a number of parameters and saw where they would choose to seek that care. We also wanted to ground those the survey data in some real live empirical data, so we looked at the state's all-payer claims database to see if it was consistent. And then we conducted 8 focus groups to try to learn a little bit more in depth what was behind the numbers we were seeing. So for the survey itself, as I said, about 1,000 Mass residents we found across the state. We wanted to look specifically at those who would be in the commercial market where some of the incentives that we're thinking about would be able to have more play. We chose some standard average shoppable procedures that everybody likes, MRIs, uncomplicated delivery, knee replacement, and we also looked at a cancer scenario. And some of the things that we tested were impacts of out-of-pocket costs, and these are all impacts on hospital choice, as you'll see. Effects of referral from your primary care physician, who might be referring you to a specialist who is housed at one of these hospital types. We looked at quality ratings using stars and convenience in the case of MRI. And here's what the choice experiment might have looked like to a consumer. They're faced with a scenario, you need knee replacement surgery, and they're given a number of parameters about 2 hospitals that they have to choose between, a community hospital near their home and one of these Boston AMCs, and we listed them, and everybody's going to know them. And we varied the quality rating for the hospital. We varied whether they had a referral. We varied their out-of-pocket cost for the procedure, and then they were forced to make a choice. Okay, so before I show you the key results slide, which is coming next, I'll show you how to understand what those results mean. So if you imagine we're starting from a baseline where the characteristics of the 2 hospital choices are the same in all cases, and the results are relative to a situation where people are indifferent. So on the right there, you see, imagine the same number of people are choosing the AMC and the community hospital when the parameters are the same. And then I'm going to show you results where one by one we change just one aspect of the hospitals, for example, the out-of-pocket cost, and then the results are cast in a way that ask, well, if you change just that one thing, what percentage of the people who initially were choosing the AMC are now going to switch, are going to shift their preference to the community hospital? So we're going to show the results as a percentage. Okay, so I'll spend a little bit of time here. Here's what these results mean. So let's look at the blue bars, which show the difference for a $1,000 additional copay for the AMC. If you look at the maternity blue bar, for example, that says that if all else equal, if the patient were faced with paying $1,000 more to deliver at that AMC, about 28% would say, given that difference, okay, I would now actually prefer to deliver at the community hospital instead of the AMC. So that's a fairly strong, that's a fairly big response. And you can see for the other blue bars, a little smaller for knee replacement and smaller for cancer. The MRI was actually just a $100 difference, which is more relevant for out-of-pocket costs for MRIs, and that's a very big percentage of people who would shift. And one more difference, the MRI case was actually not cast between an AMC and a community hospital, but there we posed, would you have your MRI at a hospital outpatient department versus a freestanding MRI center? We then looked at the effect of a referral from your PCP. Here you see the highest effect was in the maternity scenario, where almost 50% would switch to a community hospital if they were referred there from their PCP, which is certainly related to, if your OB practiced there, and people often do choose their OB based on what hospital they deliver at. Knee replacement also had a fairly high effect of a referral from a PCP. The cancer scenario did not. And then we tested the quality metric where we posed for people. Imagine there's a 4-star quality rating for that community hospital compared to a 3-star rating at the AMC. And in that scenario, you see that there were high percentages that would shift to the community hospital in the knee replacement in the cancer scenario more than in the other cases. And so the big takeaway here is that these percentages are fairly large. And secondly, I would say, as you see on the x-axis there, these medical scenarios are arranged from left to right in terms of increasing risk to the patient. And you see a higher effect of quality as you get towards the more invasive side and a higher effect of cost as you're towards the left. And that was something that we explored more in the focus groups, but it generally made sense to us. Okay, I'll try to go fairly quickly. This is testing different cost points. And just for the knee replacement in the maternity scenario, we actually had several cost ranges so that we could graph them out. And you can see that people were more responsive to it's nonlinear, so that around $1,000, $2,000 had a big effect on people's choices. And beyond that, you had a diminishing returns situation. Here I'll just note that in the side study we did on the Massachusetts all-payer claims database, the results seemed to be in a similar range. Although we couldn't do the same exact comparisons, we looked at people who did choose to deliver where they delivered, and about 20% did go to 2 of these AMCs, the Brigham and Women's and Mass General. And these choices were strongly influenced by whether there was a deductible in their plan, whether they were an HMO, and so on. And those impacted about maybe a third of the choices, which seemed in a similar range as the DCE results. Okay. So I skipped one, but we conducted a number of focus groups, and I'll kind of go fairly quickly through that, and they were quite interesting. And so before getting to that, a takeaway from the quantitative results do seem to suggest that people are quite responsive to incentives, that you would think that you'd be able to shift where they have their care. And so it kind of made us think, well, why is this so hard? Insurance, some of these parameters, such as these out-of-pocket, are typical differentials in tiered network products. So, what's really going on? And the focus groups kind of told us the answer to that, and there was a little more depressing, I would say. When you ask people about quality, for example, sure, they answered the questions, and where we told them the community hospital was better quality. But when you talk to people, they said, "Nah, I don't really believe that's possible." They have a very strong sense that the teaching hospitals are higher quality, and it's hard to convince them otherwise, even with the stars. And so that was just a factor that was difficult for people to accept. And they did also confirm that, for something like an MRI, they didn't think that quality made that big a difference, and they were more willing to move. But for something that was more invasive, it was a bit of a tougher sell. And here's a quote. Stuff like a broken bone or tonsils, I guess, would be something your local hospital could do. But something like cancer or heart surgery, you think, we've got to go into Boston to a big hospital. And that's sort of the attitude that we heard over and over again. Then another slide, we asked people about quality information, getting back at those quality star ratings. Who would you trust quality information from? And people trust their doctors quite a lot on everything. But when it comes to employers and websites, they're a bit more skeptical that what you're telling them about quality is really real. We delved a bit more about costs. After seeing those big effects of out-of-pocket, something that we learned was that, sure, if people are forced to make a choice about cost, then they would, but they really didn't like to have to make that choice. They know that these narrow network and tiered network plans will put those costs on them, and they just don't like that. They don't like having to make that choice. And something else that I'll get to, they didn't really tend to believe that if my employer has a narrow network plan that's cheaper, that those savings were going to come back to them in some way. They thought, oh, that's just some scheme for the insurance company to make money. I don't get any benefit from that. So they don't like having to make these cost trade-offs, obviously. And when we talked about referrals, confirmed that people did trust their PCPs, which they do. Interestingly, they said that when something was really complex or risky, they wanted to do some of their own research and shop around, and they really wanted to find out who were the best doctors, where can I go. So it kind of suggested that the referral effect should be stronger, as we saw in the results for some of the things that people felt were a little more routine. Here's a quote: "I like having the choice. It's like I'll do the research myself depending on what it is. If it's something my eyes, I'm going to make sure it's a reputable place, try to get research on the doctor," and so on. Okay, so here's some overall findings. People will respond to cost differentials, quality signals, and referrals, but they perceive large quality differences between these types of hospitals. They prefer the AMCs for invasive and risky stuff, and they're skeptical of attempts to steer them. And we took away some lessons from some of this, and I think some of this is related to what Christoph was saying about the employers. You have to present the information to the employees in a way they'll understand, and if they can see clearly with a side-by-side, if you're in this tiered or limited network plan that's cheaper to you, I mean, first of all, there should be real savings to the person, and they should understand that if I am limiting my choices in some future scenario, I actually am going to have a financial benefit for that, because people start out very skeptical about it. Also, resulting from the study, those differences by level of risk suggest that you should place your financial incentives on the routine care and try to steer people there. And when you're talking about the more risky care, the financial incentives might not have much impact, and there you've got to really convince them on the quality. And people tended to have a sense that quality varied quite a lot, and that even what we think is routine, people thought was risky. And if you can push that boundary so that people realize that, some stuff that you might find a little scary is really done just as well in the community hospitals. It's a tough sell, but that would probably yield a lot of benefits. And given that people did trust their PCPs and those referrals, you'd like to have the physicians include cost in their equation, and there we're talking about the global payments and global budgets. People don't like the idea that their physicians are steering them based on cost, but that's just something to deal with and consider.